And good evening, everybody, and welcome to the Oculus Clinical Webinar Series. I'm Dr. Bill Tullo, Medical Director at Oculus. Tonight, I'm really pleased to welcome a good friend, Dr. Jason Jedlicka. He's going to talk tonight about the Pentacam AXL Wave, the building block for specialty contact lens fitting. Before I introduce Jason, though, a little housekeeping. If you have questions during the webinar, please put them into the chat, and we'll leave some time at the end to answer your questions. As most people know, Dr. Jason Jedlicka is an associate professor at Indiana University School of Optometry and the chief of cornea and contact lens service. He's a past president of the Scleral Lens Education Society, a diplomate in the cornea and contact lens section of the American Academy of Optometry, and a fellow and past board member of the Contact Lens Society of America. He has special interest in studying ocular surface shape and contact lens design and is a partner in the Lens Design Solutions, a contact lens design development team. With no further ado, Jason, take it away.
Thank you, Bill, and thank you everyone for taking time out of your evening to spend this hour with me and the Oculus team. It's a pleasure as always to get to talk about how we utilize some of these great instruments. So tonight the topic, of course, is the AXL Wave, and the AXL Wave is all just like we all know the Pentacam is an anterior segment tomographer, and that's what it's really known for. But the AXL Wave is so much more. It's really a 5-in-1 tool, and we'll talk through how each of those 5 applications or functions of the device are useful to the specialty contact lens practitioner. Again, there are so many things that we could talk about. When you go into the instrument and after you capture data and you go to your display map, there's literally 30 or 40 different ways you can analyze that data. So it's such a powerful tool. And in some regards, certain practitioners are going to lean more heavily on certain aspects of the data display than others. But as again, a contact lens prescriber, we're going to hit heavily on how we utilize this instrument for contact lens prescribing. My experience with the instrument, I've had an AXL Wave now for about 2 years, and we use it every day, a lot, of course. We use it for a variety of different things. In our contact lens practice at the University of Indiana, we do an awful lot of irregular cornea treatment. We fit a lot of scleral lenses and corneal GPs. We do a lot of myopia management, so fitting ortho-K and tracking axial length, etc. And we do some, aberrometry control scleral lenses, and this is another thing that will be hopefully coming down the road with the AXL Wave, which we'll talk about as well. So my experience is that it does just about everything I need an instrument to do for me in my specialty contact lens practice, and having all of the functions of it really comes in handy. Again, the functions of the AXL Wave, the Scheimpflug-based tomography, of course, is kind of the bread and butter. Why we would consider getting a Pentacam probably originally is I want that corneal topographical and tomographical shape. I want to look at the shape of my eye. I want to know the health of the cornea, etc. And that's the critical part. That's really the core basis for any of the Pentacam units. The AXL Wave, of course, incorporates wavefront aberrometry of the eye. This is not just simply corneal wavefront, but entire aberrometry of the optical system. Again, very important for many purposes, not the least of which is troubleshooting issues with contact lenses and looking at residual aberrations through specialty contact lenses. We also can do optical biometry with AXL Wave, giving us axial length measurements, biometry, highly precise, and we'll go over how that works as well. You can also retroilluminate the visual axis and see the optical properties of the eye. This is helpful, maybe less so with contact lenses, although a lot of times our contact lens patients will have visual concerns. And as we differentiate the contact lens as the source versus other issues, this can also be in handy. But we use it a lot for, again, looking at opacities in the visual axis, cataracts, corneal scars, as well as intraocular lens centration and so forth. And then we also do get an objective refraction at the time of the aberrometry. So our aberrometer will measure not just aberrations, but also will give us an objective refraction of the eye as well. And so before we jump in, just kind of give you an overview of what all we're going to talk about tonight. We'll talk about the AXL Wave in the contact lens specialist office and the ways that we can apply this device to a wide variety of patients and patient needs. Of course, we'll talk about how we can use the instrument to screen, detect, and monitor anterior segment disease. And a contact lens practitioner should be adept at looking at these things. You know, we don't want to just be someone that handles the contact lenses and is clueless about the health of the cornea. We need to be able to understand how our contact lenses affect corneal health, and a basis for that is understanding it before we even begin the fitting process, but also then to be able to look at the effect of the lenses on our patient's eyes over time. We also want to be able to measure corneal shape for corneal lenses. And again, we talked about the tomography and the core function of a Pentacam is giving us that corneal shape. This is helpful, of course, because as a contact lens specialist, we want to be able to fit lenses properly. We pride ourselves in giving our patients a better experience with their contact lenses in terms of fit. We also will appreciate the benefit of getting full corneal data. Many of the placido-based systems that exist give us 8 to 10 millimeters of corneal data, where with Pentacam, we're going to reach to the limbus to get the full corneal data. And that will come in handy in trying to get the best possible fit as quickly as possible, especially if we're using integrated software. When our software can really understand the entire eye shape and it doesn't have to extrapolate that peripheral data, we're going to get better outcomes with our lenses more quickly. We also will want to monitor the corneal shape in the presence of our lenses, and this particularly is to say, you know, prior to beginning the process, what underlying issues is our patient dealing with? Do they have keratoconus? Do they have a irregular corneal shape? And again, getting that information before we begin is important because we don't want to fit patients in lenses if it's going to trigger the cornea to have health issues. Indeed, with our ortho-K corneal reshaping patients, we can use the Pentacam to monitor for the success of our outcomes as we look at our patients in follow-up. We can also use the instrument to monitor axial length for myopia management. Again, just another core part of the overall myopia management picture. We've got that optical biometry built right in. Additionally, measuring scleral shape for scleral lenses. Scleral topography has been around for a while now, and the traditional Pentacam units have had the CSP software, which has been great to have. AXL Wave goes a step further with the CSP Pro, and this is going to allow us in many cases to get a full 16 to 18 millimeters of scleral and corneal shape data with one scan. And that being able to do it in one scan is really important because it does absolutely give us better outcomes, more predictable, reliable data when we don't have to stitch images together. And I've definitely found as we move from the CSP 5 scan stitched image to a CSP Pro that my outcomes are more accurate because my data is just a little bit better. And so that's been a big improvement for us there. And then finally, we can detect aberrations as a cause for visual complaints and potentially as a source of being able to correct that down the road using the aberrometer that's part of the system. So we'll talk first about diagnosing anterior segment disease and briefly just how critical it is if we really want to be the best we can be at diagnosing and managing ocular surface and anterior segment disease that we've got tomography at our disposal. So this is just a corneal topography of someone with a fairly normal looking cornea. I don't think any of us would look twice at this and think, well, this has got some problems. This is just a tangential curvature map. It looks like they've got a little bit of nearly with the rule of astigmatism. There's a little bit of skewing to their to the various axes. If you look here, we do see a little bit of shift in the meridians, but then again, there's not a lot of astigmatism there. So that might just be by virtue of the fact that the patient has not very much astigmatism. And if all we had was an anterior corneal map, we might not think twice about this patient, go ahead and fit them in whatever contact lenses we desire to fit them in, and off we go with life. However, when we look further at this patient's eye, we see some questionable findings. And in particular, even as you see in the upper left, the Bell and Ambrosio enhanced ectasia display is not detecting keratoconus in this patient. But if you look where I've got my little highlighter here at the anterior elevation of the eye, the front elevation and the back elevation, we do see that the patient's back elevation is a little bit greater than the front. And that should cause us to have a little bit of concern, especially in a younger patient, that this patient may actually be at risk for having early stage keratoconus. The corneal thickness looks pretty decent at 5/16, but again, corneal thickness alone doesn't mean all that much. And in fact, when we look at the patient's other eye, we do see that in fact they do have keratoconus. The left eye is more advanced. If we look here, we do see our Bell and Ambrosio display showing the signs of keratoconus, as well as if we look at our front elevation compared to the back, we see our back elevation is again higher in elevation and noticeably more so than the right eye was. So this posterior elevation is a critical screening component, and that's something we don't get with traditional corneal topographers, and what sets apart the Pentacam as the ideal device for detecting keratoconus at its earliest stage and then managing it for progression going forward. Here's another topography of a patient we can see, and this one looks like keratoconus, and this patient might get a diagnosis if this is all we've got for information. We do look at this patient's cornea though, front and back. What we can see is their corneal thickness is quite robust at 5/88. And our front and back elevations, if we look here where my little highlighter is on the front elevation compared to the back, we see very little difference there. Our back elevation and front elevation are both about +4, so they match. So this patient certainly has some corneal issues, some warpage or whatever is going on. Certainly it's not a regular anterior surface, but this is not due to corneal thinning or ectasia as the diagnosis. So we wouldn't be looking at managing this patient for keratoconus so much as we'd be trying to discern why is their corneal surface irregular and try to manage it that way. Just another great example. These are two different patients of mine who both were quote unquote diagnosed with post-LASIK ectasia, and both were referred for contact lenses, but meanwhile they were managed in other practices as well. The consideration, of course, being, do we cross-link, do we treat, for so on and so forth. The patient on the left, clearly if we look at their anterior curvature map, is a very hot spot inferiorly. And again, we look at the front elevation map, if you see where my little highlighter is, and we look at the back elevation. The back elevation is absolutely protruding. The corneal thickness is, not only is it thin, which we'd expect from someone who's had refractive surgery, but the apex is pretty well decentered outside that 3mm ring. So this patient clearly does have a corneal ectasia in the wake of having had LASIK. Now the patient on the right here, we see a similar inferior steep pattern, and we do see a fairly thin cornea at 425, again, not unusual for someone who's had refractive surgery. We can see that in this case, the apex of the back surface, or the thin spot, is right in the middle. And if we look at the front compared to the back elevation, there's no indication that this patient has any type of ectasia or thinning disorder. So it was my impression that this patient, while they have some irregularity to their cornea post-LASIK, it is not ectasia, and I would not refer this patient for cross-linking, but just simply monitor the situation. So again, just to kind of summarize, to detect corneal ectasias as early and accurately as possible, I think you can see you really must have a corneal tomographer. Surface topography is just inadequate. To monitor corneal ectasias as effectively as possible, again, we really must have a corneal tomographer. If we want to try to serve our patients well and catch and manage their keratoconus or corneal ectasia as effectively as possible, giving them the best opportunity for halting any progression or further deterioration of their disease, we've got to have corneal tomography. And again, a specialty contact lens practitioner should have a full understanding of the cornea they are fitting. We don't want to just be a contact lens fitter who is not able to look at that cornea and detect whether our lenses are having an adverse effect on those corneas. We want to be able to be an astute clinician, even as this patient may see other doctors. We certainly want to be able to care for them the best we can as well. Regarding that keratoconus progression, as we mentioned, again, there are built-in progression displays. This can be very helpful for understanding whether our patient is progressing or not. You've got, when you pull up this display, you don't have to import all of these tests. The instrument will go through the patient's test history, and it will immediately pull all the data from their previous Pentacam tests into this screen. And so it's convenient in that you get a snapshot of all of their prior Pentacam measurements, their corneal tomography measurements from their history pulled into one place where you can look for changes in the anterior or posterior corneal curvature, the thinnest area on the cornea, as well as any changes in vision. And it will go through and take those values and put them through an index for us and predict whether it believes that the keratoconus has progressed. So a very helpful tool to be able to, again, look at everything all in one snapshot, quick and easy, get an impression evaluation. We use this, again, regularly for all our keratoconus patients just to quickly detect whether we think things have changed. If there's anything fishy looking on our progression display, then we will pull up the individual maps a lot of times, look more carefully. But again, this gives us a quick look so that we don't have to look through multiple images to make that call. Beyond, the diagnosing and management of corneal disease, we also can monitor for side effects from our lenses. And again, having the corneal thickness measurement of a tomographer going for us, and not just it's not even that you couldn't do pachymetry, let's say with a handheld pachymeter, but in this case you get just the full corneal shape data, whereas a pachymeter is giving you data about one spot. And so if you're looking for subtle effects, subtle signs of corneal edema, you may not always detect that very accurately with a basic ultrasound pachymeter. In this case, we had a patient in the upper left, a 63-year-old male post-PK, scleral lens wear, complaining at a follow-up a few years later that the vision seems to be getting foggier. As you check the acuity, it certainly has dropped off from 20/30, 20/40 to about 20/50. And the concern is that, is this graft failing? Is the scleral lens aggravating the situation and creating more corneal edema? And in fact, we do repeat their Pentacam and find that their cornea is, about 20 to 30 microns thicker. So this patient indeed was developing corneal edema from their lens. Fortunately, we took this patient out of the sclerals, fit him in a corneal GP for a couple of years until he was able to have a DMEC done over his graft, at which point his cornea cleared and we were able to refit him in a scleral and get him back to 20/20 vision again. So that just kind of summarizes, again, the use of this, how we use it every day for our anterior segment disease patients. Moving now into just basic corneal shape information. The Pentacam is a powerful tool, but that doesn't mean you can't use it for garden variety everyday function. And there's plenty on a basic one color map display to help you with better fittings, just our basic soft lenses or corneal GPs. We've obviously got our K readings. We know our corneal thickness. We know our horizontal white to white. Anterior chamber depth gives us an idea, again, of the sagittal depth of the eye. Again, this is true corneal data. This is not extrapolated, interpolated. This is everything you see on this map is true measured data, and that is getting out, again, to a full corneal coverage. So this information is very helpful, again, for just picking out lenses for any patient that you're fitting in contact lenses, be it specialty or not. Again, we use this device a lot for our ortho-K patients. There was a time some years ago when we were still doing a lot of ortho-K, and I just felt like my keratograph, my placido dystopographer, was adequate for fitting and managing my ortho-K patients. And what I came to the realization was a few years ago that in order to be more efficient and effective at getting less remakes and getting my fit faster, I needed the full corneal data that a Pentacam gives. And so now in our practice, we do also use our Pentacam as well as our placidodisc topographer, both for our ortho-K patients, because you never know when you're going to want to have one view or another. But having that Pentacam at baseline, again, allows us to be much more efficient with our first lens fits as we use that data to create the best possible lens for our patients. So before we begin an ortho-K fitting, one of the things, again, that Pentacam does for us is it screens for poor candidates. And the difficulty is when we're fitting, a 7 or 8 or 9-year-old child in ortho-K lenses, and once we start reshaping that cornea, our keratoconus detection indices are kind of useless, or they're just not accurate because we've now flattened our anterior cornea so much that a lot of times when we do a keratoconus index on someone who's had, let's say, ortho-K, it just kind of gives us it'll predict, has this patient had refractive surgery or something, but it's just not an effective tool. So one of the beauties of having Pentacam corneal tomography prior to beginning the ortho-K process is it will screen us for poor candidates. And while the number of children who are not good candidates for ortho-K is very few and far between, there are some that are. We just don't want to miss that. And so again, this is just a case where if you only looked at the tangential curvature map in the upper left of each eye, you would probably look at that and say, that looks pretty normal. K readings 45.1 by 45.5, 45.1 by 45.3. That sounds symmetric. This seems like just a fine candidate. However, because we've got more information from our scan, like corneal thickness, which we often wouldn't have for an ortho-K patient necessarily, we can see our pachymetry in both cases is under 450, very thin for a 7-year-old child. And then in addition to that, if we start looking at the front and back elevation maps, well, the back elevation map is not more elevated like we would see with a corneal thinning disorder like keratoconus. There is some irregularity here, and this patient would probably be best suited to monitor and check their Pentacam again, and maybe hold off on ortho-K and consider some other myopia treatment options. Or if we did embark upon an ortho-K treatment, we would want to monitor them carefully with repeat Pentacams at regular intervals to look for any signs of change in that back elevation map. And again, this is just that same patient we just looked at, put through the enhanced ectasia display, and we do see some kind of caution flags even showing up here that this patient might be a concern for having keratoconus. So just something that we would otherwise not detect without this tomographical data that we get with our Pentacam. Another benefit of using the Pentacam for our patients that we're going to fit, perhaps using a software basis, or we need that data to be really accurate, is that it's not tear layer dependent. Again, a placidodisc topographer is going to be tear layer dependent, and these two images you see are the same patient. One on the left side is with our placidodisc option, and the one on the right is without, and you see a cleaner display on the Pentacam because it is not tear layer dependent. Now again, there are pros and cons to both, and that's why we do both if we have that luxury. Sometimes I do want to see the effect of the tear layer on the eye, but I don't want that impacting my baseline information. I want my baseline information to be true corneal shape without the tear layer potential disruption. And that, again, especially if I'm going to be using this map to create custom lenses for our patient, I can't have that disruption of the tear layer interfering with my lens design. Again, I can't say in the last couple of years as we've moved towards just a different strategy for our ortho-K fitting, where we get Pentacam on all of our patients along with a keratograph. And then we use integrated software such as the Wave software, which is built right in. You can get built right into your instrument. So it's just a matter of connecting to that external software. It immediately uploads your map and it immediately does your lens design for you. We get images like the picture on the right all the time. First lens. So our first lens success rate is through the roof because our data is better, because we have more true data rather than extrapolated data. And we have a software that we can then use that takes all of that data and uses it to really make the best possible lens for our patients. So we're having great success with this system. A lot of times, again, our patients will come in, we'll talk to them about myopia management. We'll talk to them about ortho-K if they're interested in ortho-K. We just simply get their scans done and their refraction, and we say, we'll see you in a couple weeks when your custom lenses are here. And we get into our software and shoot off the data, and this is what we get, again, the vast majority of the time. And this patient has actually been in ortho-K lenses now for about 4 years and going strong, doing very well with their treatments. You can also tackle more complex ortho-K patients because you have this vast data about the corneal shape. And again, you can export that data into programs that will use that full corneal data to create for you the best possible lens. This is a patient with 2.5, 3 diopters of corneal astigmatism. And you, as you can see by their curvature maps, but you look at those lenses and you would have no clue that this patient had any astigmatism. It's really a glove fit on both right and left eye. And this is something that would be very challenging to do by simply getting a placido disc topography and diagnostically fitting that patient. That, again, that integrated software really is helpful, especially tackling more complicated patients. This patient that we're looking at here is actually a 28-year-old female who wants ortho-K but has a high prescription. We're talking about close to -6 with 2 diopters of astigmatism. This is a case that if I had to rely on just simply using diagnostic lenses or empirically fitting with just Ks and Rx, I wouldn't feel very comfortable about proceeding with a patient like this. But given the Pentacam data and given the ability to use corneal shape information to help build my lens and make them more accurate, we tackle patients like this all the time. And we end up, again, with fits where they're centered well, with a very solid ring of alignment despite the astigmatism. And again, a good visual outcomes for these patients. 2020 is expected even with more challenging cases like this. Moving on to the axial length aspect, because again, we have been talking about myopia management with orthokeratology. And again, you've got optical biometry as built in with the AXL Wave. We can use this, as I mentioned, for our myopia management patients. I can use it for any patient you need biometry. We're going to get 6 readings. You're going to see your signal to noise ratio and some of your offsets off the visual axis. And you can click on each of those 6 readings to actually look at the display at the bottom. We've got our signal to noise essentially in both cases showing a really strong peak with very little noise. But if you have any readings that are a little bit outside of the majority of the other 6, you can certainly look at those and evaluate them for accuracy and remove them if you feel like there's too much noise. So again, this is an easy way to have our myopia management patients at the time of their Pentacam. We can easily take their axial length, and as we do their follow-ups, as we do their tomographies at their follow-up appointments, it's easy to just go right on over and do an axial length scan at the same time. We don't have to move that patient to a different instrument, for example. It's just simply working our way through the full sequence. And so next thing I'd like to talk about is how we use the AXL Wave to fit scleral lenses. And again, just a couple thoughts. The picture on the left you're going to see is the CSP 5 scan. And again, this is a great tool, a great test. If this is what you're using, it certainly works very well. We used it for a few years prior to getting the AXL Wave, and we were getting good outcomes, to be sure. But it is definitely more time consuming. You've got to take 5 individual scans. They've got to be able to be stitched together with a level of accuracy and compatibility to make sure that you're getting good data. And again, you still have some stitched points, and that always leaves a potential error, room for error when you're stitching together various images. If you look at the image on the right, again here, what we see, this solid yellow fill means that we've got all of our data that we need for our entire topography in just a single scan. Okay, so when we have to stitch multiple scans, you'll see that we may have a little sector here or there. It's a different color, and that just means that it took you a second scan to complete the data that you wanted to obtain. But again, not only is it faster, I do believe personally, and I haven't studied this, but I do believe that the single scan gives us better data. I find now that as we use our data from the CSP Pro in those patients where we are able to obtain the full data in a single scan, I find that the data is extremely accurate. It's just so predictable that when we decide to fit a specific diameter lens, we put a diagnostic lens on, the central clearance, the edges, everything look exactly like what we expected. There's no surprises where you throw the lens on and you have 800 microns of clearance or you have corneal touch because your predicted sag value was not close, and we don't get that. So I truly believe that the CSP Pro is a noticeable improvement in accuracy over other types of corneal or scleral topography, mainly again because it's able to do it in a single scan and it is tier layer independent. So again, you don't need to have any dye, you don't need any reflections. This is all done without reflections, so a more accurate test. One of the things that I would say as you look at using a CSP Pro and how we are getting our full corneal data more predictably now with a single scan, we've gone to anesthetizing our patients for this. And even though it doesn't hurt, by having their eyes numbed, they're able to hold them open wider. I mean, obviously we're holding them open for the patient, but there's less resistance, there's less fighting the holding their eyes open, and they are able to hold them open longer. So there's no reflex to want to blink in the middle of our scan or as we're trying to get things lined up. So we've had great success with doing that. And again, the majority of our patients now, we are getting single scans for their scleral topography. This is an example of a patient that you can see, and this is a great example because if you look at our coverage map now, as I mentioned, it's mostly yellow, but there is a little sliver of blue. And what that means is with this patient, we took 2 scans, and the first scan covers, 90%. It's actually got 100% coverage in the 15 millimeter zone, but we took another one and just added a little bit more data in this area where there's a little bit of light blue. So that is stitched data. But this patient has obviously lots of astigmatism. You can see the scleral and corneal topography both show an awful lot of against the rule to slightly oblique astigmatism. In this case, we took the data from the CSP data using the ring diameter that we knew we were going to fit, using the measured astigmatism values, the predicted sag values, etc. And we made this lens just strictly off of data. And you can see by the picture on the right is a really great fit. The patient was very comfortable for a new wearer, and 2015 vision once we adjusted the over refraction a little bit. I'm extremely happy, but again, empirically designed strictly from the data from our CSP Pro. Another example of the very same thing, this is a patient with a somewhat more complex eye shape. We've got, if you look at this, our elevation map, and look at my little highlighter here, we've got a with the rule cornea, but our sclera has got a different shape. In fact, our axes of our flat meridian are not opposing each other. They're a bit oblique to each other or skewed again. And so what we were able to do with this individual is to create a lens using quadrant-specific chamber and haptic information, again, using the CSP Pro data. And so this data, because it is so accurate, in my opinion, I'm very comfortable using this data to empirically create lenses for our patients and get good outcomes, and save a lot of time from having to diagnostically fit routinely. And then, of course, we can certainly use integrated software with this again, just as we did with our Ortho-K lenses. There are a few different software programs that will integrate with the CSP Pro data. And again, we can simply upload our map to that program, go ahead and choose the parameters we want, like the diameter we want, the center thickness that we desire, etc., whatever we think would be best for our patient. We can then, as we dispense lenses, if the patient needs modifications, you have simple fitting tools that will use that data along with the software to adjust things like your edges, your limbal clearance zone, your central clearance, etc., in a very simple way. So, and again, this is that same eye that just showed you using the CSP Pro data with an integrated software where we uploaded it and it created a lens. And you can see the picture on the right. The vault is really good, certainly very dispensable, somewhere in the 300 to 350 range. Our fluorescein pattern on the general fit on the left looks nice and uniform. So again, one lens fit out the door to try it at least, and then come back for reevaluation and potential modifications in a week or two. Finally, I'm going to wrap up talking briefly about the aberrometry aspect of the AXL Wave. And again, this is something which is unique to the AXL Wave. It's got the wavefront aberrations in it. It's simple to use. Again, it's done right at the device. You can do it at the time of any other testing if you have an interest in the patient's aberrations while you're collecting their corneal shape data or axial length, etc. A nice thing to use, again, maybe for our Ortho-K patients, just to understand their visual quality as they are going through the Ortho-K process. But you can see an image on the left, and this is a patient with fairly normal to maybe smaller size pupils. And you can see the data showed here. All these indices are fairly normal. Our residual HOA is 0.168. That's pretty low. So this patient should have no issues with visual quality due to aberrations. Moving over to the right, this is another patient with just large pupils. You can see how much larger they are in the photo. And when we take into account the full 7-ish millimeters, this patient actually has 7.35 millimeter pupils. If we open up the zone that we're looking at with our aberration map to 7 millimeters, you can now see that our residual goes up above 0.5. This is going to be probably in the symptomatic range in different lighting conditions. You also can look at the actual data points down in our Hartmann-Shack aberrometer in the lower left, and you can see how much more skewed these points look, how much really spherical aberrations we're dealing with in this patient with larger pupils affect the quality of vision, as opposed to the picture of our other patient where most of these dots are quite discrete and compact. And so again, really helps understand our patient's visual function when we can look at a quality aberrometry map. This was a patient I actually saw in the last month or two who came in just for her annual exam wearing soft contact lenses and kind of complaining about poor quality night vision, hard to focus, lack of clarity in general. We over refracted through her contacts, took the contacts off and refracted, and we didn't find any change in prescription at all. So I was concerned. But the thing that you notice again is this patient has very large pupils, measured at 8.31 at time of aberrometry here. And again, this patient just happened to be on some different medications, one of which in particular has a side effect. It's actually a derivative of atropine, and not for myopia management, but simply for like restless legs. And so she was taking a medication, which was an atropine type drug, which was having the effect of giving her some pupil dilation, and I think even a little bit of cycloplegia because she was having trouble focusing, only 23 years old. So again, we were able to explain to our patient exactly what was going on. Her residual HOA is almost 0.7. Certainly that's going to be visually significant. and help her understand that it's not just a change in prescription you need, it's more than that, and actually working through her medications even with her doctor to see if there's something else that she can use. Again, finally, just to kind of wrap up this aberrometry section, we know where we're going with scleral lenses. There's increasingly options for putting HOA correction on the front and helping our patients with irregular corneas to see better. That's something which is in the future. It's not there right this moment on the AXL Wave, but something that would be great to have happen in the near future, where using our aberration maps we obtain, perhaps even integrated with the scleral lens fitting process. We have an application for putting wavefront corrected front surface on scleral lenses. And so again, this is a patient, if you look at the bottom right, the infrared image, you see this patient has a scleral lens on their eye. This is a patient with keratoconus who wears sclerals, and again, complaining of not the best quality of vision with their lenses. And we look and you can definitely still see this residual coma that is coming through because of their keratoconus. So again, aberrometry helps to explain, helps us to do a better job with our specialty patients, help them understand where they're at. You know, this is really just the tip of the iceberg. I've only talked about some of the things that are really relevant to the specialty contact lens practice. And there's so much more on this instrument. It's ridiculous. It's used obviously extensively in refractive surgery, cataract, pre and post-op management, et cetera. And there's just a wealth of data that can be obtained with the AXL Wave. It really does just have such a vast application to all types of patient care when it comes to vision and the anterior segment, from routine care to the most complex case. It really can do it all. Diagnosis and treatment of the anterior segment disease, as we mentioned, elevating your contact lens fitting skills, your abilities to take on more difficult cases, to be more efficient where you're fitting a patient, and again, to be able to explain to the patient, I'm making you a custom lens that's just made specifically for the shape of your eye. And when that lens comes in and it works, you know, at a very high rate the first time, it's very impressive to patients. And so it saves chair time, it makes you more efficient. And I just think that, again, often people will look at the cost of an instrument like this and say, that's expensive. And I say, but how can you put a price on the efficiency and the confidence that is instilled in your patients and you as a practitioner, that this instrument can provide? So that the technical, the impressive technical side, the efficiency, and again, just giving your patients good outcomes quickly and efficiently leaves a lasting impression. Again, more comprehensive myopia management, because not only can we scan our patients, create their lenses, but we can monitor their axial length even as we're mapping their corneas at, you know, at the same session, so that we can continually update all of that data. It does give you the ability, again, to really elevate your scleral lens fitting, and whether that's you using the data to diagnostically fit, whether that's you using the data to guide your fitting process, to be your fitting process, or simply to let software do the heavy lifting for you, they all work. And so getting better fits, controlling your adjustments, understanding the shape of your eye underneath that lens, the instrument really can do all that for you. And again, with the CSP Pro, more efficient, faster, and just more accurate. And then finally, the aberrometry component, which again, right now, is very helpful in helping understand patients' visual system, and hopefully in the future, as things evolve, will even come into practice more for us as specialty lens fitters, as we can potentially use that information to enhance our scleral lenses. So with that, that draws my presentation to a close. I have plenty of time for questions, Bill, if we have anything we want to talk about.
Awesome. Yeah, we have some good questions. I want to start off with something you just mentioned, and I want you to put your crystal ball on, and let's pretend 5 years in the future. What percentage of your scleral lens patients you think that you would think would benefit from high order aberration correction? Is it 5%? Is it 50%? I mean, if you looked at all the people you
Yeah.
fit right now, how many you think would benefit?
You know, here's the truth. If I knew that the lens I was fitting them with fit them really well, very stable, no rotation, no movement, just locked in. And I know that we're getting better all the time at making that happen with the freeform options and the more sophisticated designs. I think that in 5 years, if I had a lens that I knew would center well and be rotationally stable really well, I would put it on, I'd put on everybody with keratoconus. I'd put it on a percentage of all my patients. I think what holds me back now is that I'm not always confident in that the lens I'm going to fit with these higher corrections is going to stay put on the eye all day long while they're wearing. So I could see that number in 5 years being anywhere from 25 to 50%, honestly, if the if the lenses and the system for incorporating HOAs was more efficient and more effective. And so I look forward to us continuing to evolve our ability to fit precisely, because that will again allow us to incorporate these on more patients than just the ones who really are desperate for it.
Excellent. I agree. I think the asymmetry of most of the aberrations that are visually significant make it a challenge. And I think obviously scleral lenses are ideal compared to corneal GPs for getting that stability. And I think we are getting closer and closer. So I'm really looking
Yeah.
forward to that future where we can actually help our patients see the quality of vision see a lot better. I have
And
another
you know,
question
Bill,
for you.
and I was going to say, you know, from your time in refractive, what percentage of patients, given the option, have custom LASIK over not? I mean, in the refractive
Yeah,
practices I work
in the
at,
last decade, virtually all of them. Yeah,
virtually all. So if
yeah,
you're going to go through the trouble of getting a scleral lens anyway, why would you not put on better correction if you could?
yeah.
If you
It
knew it was
makes
going to work.
total
So
sense. Yeah,
yeah,
and I'm sure that the tools will get better and the processes will get easier also as time
correct.
evolves. A question for you. I want to share my experience with you, and I'm going to see if you had a similar experience. We've both been fitting scleral lenses for well over a decade. And for me, 3 years ago, I started using profilometry on all my patients. And it was a crazy eye opener seeing what the sclera actually looked like versus what I thought it looked like. I would say I probably used toric haptics 5 years ago, maybe 5% of my patients. Today, I either use toric or freeform haptics on almost all my patients.
Yep.
And things like midday fogging have virtually disappeared. Can you just share your experience on profilometry and how it changed what you do?
Well, absolutely. You know, it used to be before that, we would fit a scleral and I would go grab my fitting set and I would just throw a lens on. And, you know, I'd have to sit there and look at it and study it and try to figure out what do I need to change and how much do I need to change it. And now I look at a map, and even if I'm going to diagnostically fit, I can look at a map and within about 30 seconds, I know which fitting set I'm going to fit them in. I know which diameter lens I'm going to choose. I know what sag lens I'm going to put on. I know whether I need a toric vaulting chamber and or toric haptic or quad specific. I know all of that before I ever put a lens on the eye. So when I put a lens on the eye, it's really just to confirm what my map already told me and over refract them. And it just means that, again, you know, the days of putting 3 or 4 lenses on each eye to get a patient fit are gone, and patients are happy about that. Nobody likes multiple attempts at putting scleral lenses on their eye over and over again. So it just, again, like I said, even, you know, sometimes you look at a profilometry and you'll go, this eye is crazy complicated, and you'll just move right to a freeform because you know right away, I don't want to beat myself up trying to fit this. But you might also see some very normal eye shapes just with just some toricity and think this patient will do just fine with something simple and diagnostically fit, and I'll go grab a lens, throw it on over refract, order, and you know, and we're good. So it just changes the whole dynamic to, instead of trial and error, you know, again, moving far away from the art and as much more towards science as we can.
Can you also comment on the patient experience of being fit with scleral lenses and the less number of trial lenses you need to put on now that you use profilometry.
Sure. Well, it makes you look good. It makes you look like you know what you're doing. When you can put that lens on and you say, "How does that lens feel?" And they say, "It's pretty good." Yeah. And sometimes I'll even say, like, maybe you'll know that the patient has a lot more toricity than what my diagnostic lens is going to have on it. Okay. So I know they're going to feel it because I know what they've got going on. And so when I put that lens on, I say, "How's it feel?" They say, "That's not too bad." I say, "You feel a little bit down around 4 o'clock, don't you?" And they say, "Yeah, how did you know that?" Well, that's because my map told me your eye was a little curvier there and the lens doesn't match it quite right. And you just sound like a genius, but it's really just the data directed you to know what to expect. And so you could literally go in there and predict what the patient's going to experience. And again, it just the patient's confidence. They just think that you know what you're doing.
Yeah, I always dreaded the initial dispensing of the first scleral lens with the fear that it wouldn't be good enough that they can leave with it, which undermines the confidence in everything, in the doctor, in the system, in whether they should even be wearing a scleral lens. And that happened, I wouldn't say infrequently prior to profilometry. Now, if it happens, it's extremely rare, and almost every patient can get to leave with that first lens, which really confirms the process and really gives confidence to the patient that this is what they should be doing, especially if they're a long time corneal RGP wearer and you're transferring them and they're not sure they want to do this. And so it just, I mean, for me, it actually helps so much in getting that first lens on the eye and wearable. Even if I have to do minor adjustments, the adjustments are usually not major anymore.
Right. And I'd say the number one reason now for a lens to not be dispensable at the first visit is I've got a crazy big over refraction and
Mhm.
like I got a +7 over refraction or something like that. So I know, oh gosh, between vertexing and whatnot. And I'll even tell the patient, I say, gosh, I'm pretty sure your lens is going to fit well, but the prescription may be a little bit off when you come back. If we have to, we'll adjust it. But I think that prescription issues are the main reason to not dispense a lens for me now more than fit.
Yep, I would totally agree with you, and it's usually the higher distorted corneas where you get those surprises,
Yeah.
and it doesn't typically happen with your more normal shaped corneas.
Correct.
You mentioned with Ortho K, and it's been my experience also that your one and done rate, since you've been using the actual data from the Pentacam versus a placebo topographer, has gone up. I know mine. I thought I was a really good Ortho K fitter with a 70% one and done rate, and then switching to using the Pentacam data and designing lenses, I'm now at about 96% one and done, and it was shocking. I didn't really expect to get that much better. And do you think it's, in my theory, it's the data that's from 6 to 9 millimeters? It really, because we're fitting such larger lenses now to get that beautiful centration. I really think it's that data that was from the return zone outwards. It really, we were extrapolating and guessing, and now we're not guessing at all.
Yeah, I completely agree. And it again, because when you know that data out there, you can create lenses that are, again, toric or quad or freeform, and you can really hug that peripheral cornea, and that helps centration a lot. I've even had several patients over the last few years where we may have gotten a Pentacam on them prior to fitting them with other lenses, and we fit them with just diagnostic lenses, and they didn't really work as well as we'd like. They maybe decentered a little bit. And so we went back and they had, even a year later, we went back and picked up their original map from before we ever started. And we designed them lenses using that full corneal data with a more of a custom approach. And we didn't even wash out the patients. We just switched them midstream, and you could see after a week or two things centering up better and just getting a better outcome. So yeah, there's no question that what we accept as an acceptable outcome has changed. I used to be content if the lens was, if the patient wasn't complaining, and the lens
Right,
could be
right, exactly.
decentering
Yeah.
significantly, and the cornea looking a little bit warpy, but yeah, the patient's happy. Now my standard is higher, and I know we talked at GSLS last week about the idea of there was research that shows that a decentered ortho-K lens actually gives better myopia control. So what's wrong with having some decentration? And my answer to that was I'd rather like to control the decentration myself rather than have it be left up to, you know, the ortho-K gods or whatever. Um,
Exactly.
I I want to create that red ring where I want it to be, not have it be, you know, well, I'm not very good at fitting, so this is the best we can get. And oh, by the way, my excuse is I get a better outcome. I can do better than that. I'd rather adjust the treatment zone myself and get it to be smaller if I want more red in the visual axis. So again, I think we can do better. I think our standard for what is a good outcome has changed. What I thought was a good outcome 5 or 10 years ago, I probably would be a little bit embarrassed about today.
And that brings up one more question I have for you. I had, from my practice, I've been fitting RGPs for 35 years, and I have a lot of keratoconic corneal GP patients that have been wearing, in my initial designs that were like 9.0 diameters. And when the cones are not centered, which they often aren't, those patients, while they may see well, they have a lot of glare and halos. And over the years, decades ago, I would try to refit them with bigger lenses, and it would never work. And recently, now having the Pentacam data, I've actually redesigned large freeform lenses, and I've been astonished at how well they do work. Have you done similar things with corneal GPs?
Yeah, I've got a few I've been working on. I think it's been one of those things where in the last year it's kind of been a new thought to move that route and see, you know, we can certainly create, if we create a larger diameter lens, of course, we can create more alignment out in the periphery. Then we can have a little bit of a larger optic zone and control that clearance and keep out the bubbles. And I think you can make it happen. And I do see the potential for more of that again as we can create these nearly full corneal lenses with a controlled amount of apical clearance. And not only that, is one of the other nice things that we'll be able to do more of, and we can already do a little bit, is decentering the optic
Exactly.
zone in our lens. And so if our lens does ride low a little bit, you know, or ride high or whatever, decenter in a direction, we can always move that optic zone, you know, a 0.5 millimeter or something like that. Not a lot, but enough to maybe get rid of some of the visual issues and just create a more uniform fit too.
Excellent. And the last question I have is actually a generic question asking, is there any textbooks or guides that you would recommend as far as learning how to read topographies? Um, I'm just going to quickly say that Oculus does have a Pentacam interpretation guide, and you can just Google Pentacam interpretation guide and you can find it on the internet, or you can send me an email at btullo, T-U-L-L-O, at oculususa.com, and I'll send it to you. But Jason, is there any resources that you'd recommend? I know all the textbooks I know, typically by the time they're published, they're kind of outdated, but you may have a
Yeah.
resource that I'm not aware of.
No, I would agree. I think, you know, textbooks are great, but we've moved into an era of PDFs online and, you know, kind of magazine length references. Again, there's a textbook that I wrote a chapter for a few years ago on custom or contact lens design using topography, but I can't even remember the name of the book. So um, honestly, I don't have a name of something off the top of my head. I think what you mentioned is great. And I think ultimately you need a reference which is specific to the instrument you're working with, because you've got
Exactly.
things are called different names on different instruments. And as we know, there's how things are presented is a little bit different. There, you know, for example, there's an ortho-K lens design out there, and you can give them, you know, the Ks, the RX, the corneal diameter, and you can give them corneal eccentricity, and they'll help build the lens. But depending on which topographer you have, they have a different formula for how they use the eccentricity. So I think it's probably vital to just say, you know what, whatever instrument you have, just get to know it really well and understand how it presents the data to you, more than a generic book that talks about everything.
Yeah, reaching out to friends that use a similar instrument are also very, very helpful. Experience is the best teacher. I find that a lot of the printed things often either outdated or not always as accurate as they could be. So talking
Sure.
with people that use the device and have lots of experiences is a great way, but the interpretation guide is also very good also.
Absolutely.
Jason, what a wonderful presentation. I always learn so much when you speak, and I really appreciate you sharing your knowledge with us tonight. And I want to thank everyone for attending tonight, and the recording will be available in about a week or so. And everyone have a great night. Thanks again, Dr. Jedlicka.
Thank you for having me.
Take care, everybody.